So, thanks for having me come talk to you guys today. I've been asked to talk a little bit about the surgery for melanoma, so I'll talk a little bit about that. I know a lot of you guys have been through it before, so I hope I don't bring back any bad memories. But in structuring the talk of what I wanted to talk about, I formatted it this way. We'll talk a little bit, give you a little overview of melanoma, and then we'll talk about how it presents and how Dr. Whitman and I work it up. The important things we're thinking about when we're doing it. And then we'll talk about the surgery, and I've divided that up into two parts. One, how we treat the primary lesion, and then two, how we think about the lymph nodes, the regional treatment of the disease. So we'll talk first about the overview. You know, every cancer talk you go to at any meeting is going to have this standard epidemiologic slide. So here it is for melanoma. There's about 62,000 new cases a year of melanoma. It's one of the fastest growing cancers. This is back in 2008. There's already more. The number's already higher now. 8,000 people die of this each year. The median age of diagnosis is usually in the late 50s, and there's a lifetime risk of 1 in 55. That increases if you have risk factors. Some of the risk factors are known in family history. Prior history of melanoma, if you have one skin cancer, you're at a higher risk of getting another skin cancer. If you have a lot of multiple clinically atypical moles or nevi, there's a genetic syndrome with P16 mutation, and then probably the majority, the biggest risk factor is having fair skin and having sun damage to your skin over years. 5-year survival. Thankfully, most patients present with early melanomas. So if you have a early melanoma localized disease, less than 1 millimeter, 5-year survival is about 95%. As it increases in thickness, the survival gets worse, 50 to 90% if it's greater than 1 millimeter, depending on the depth of the lymph node status. And then if you have lymph node status, the survival is worse, 20 to 70%. And you see there's a big range in that. It really depends, too, on the primary depth of your melanoma and other factors. And then distant metastatic disease obviously has a bad survival with less than 10% 5-year survival. Now, I do want to put the caveat, this is 2008 data. This is probably much different. The numbers are much better now that we have the newer drugs, Yervoy and PD-1 inhibitors. So let's move on to clinical presentation and workup. Almost all of you guys know the ABCDs of melanoma. So this is what the dermatologists are thinking about when they see it in the office. A stands for asymmetry, so the mole looks different on one side than the other. Say if you draw a line through the center and it looks different on the other half, that's something to worry about. B is for border, and what we mean by that is it doesn't have this smooth border like this. It has an irregular border, it's uneven, there's crustiness and notching to it. Color is for mainly color variation. If the color is in a uniform color, if it changes color, like the one on the right here. Diameter, they say typically greater than a pencil eraser. And then E is for evolving, meaning it's changing over time. You notice that it's changing. Typically, in order to make the diagnosis, you need to get tissue. You need to do some kind of biopsy. The most common way is doing an excisional biopsy called a shave biopsy, where the dermatologist just takes a little shave of your skin off. Typically, they want to get a little margin around that of usually 1 to 3 millimeters, so they can make sure they got all the mole out. One of the things they want to think about when they're doing this is you sort of want to orientate how you do that shave biopsy so you can think about how you're going to treat it later on. So if you're on the extremities, you want to orient that longitudinally so that when you excise it, it's easier if you have to do an excision. Now, in some cases, it's difficult to do a shave biopsy, say the bottom of your foot, your face. In those cases, the best way to do a biopsy is a punch biopsy. That's basically you take a little sliver of tissue out. That gives us the most accurate depth of it, so us as surgeons prefer punch biopsy, but a shave biopsy is probably how most people end up showing up to our office having had done. Now, when you get this path report, there's some key components that are always included on the path report, and they mean a lot to Dr. Whitman and me. The most important key components are up here, which is usually the Breslow tumor thickness, whether or not there's ulceration, the Clark level, mitotic rate, or margin status. There are also some other components that are on this path report, and some of them which the American Academy of Dermatology recommends. They aren't as important to us, and that's vertical growth phase, presence of tumor infiltrating lymphocytes with TILs, regression of microsatellitosis. But we're here to talk about how we think about this, and when we look at this path report, what we're really thinking about is, what we're really looking at is basically what's the chance that these melanomas have learned how to do the bad things that we don't want them to do. And if you think about it, when a cancer starts, when it first forms, it's got to learn how to do two things. One, it has to divide and ignore the cell signals from your body. Because basically, your body tells every cell in your body when to divide and when not to divide. So one of the first things the cancer has to do is it has to learn how to ignore the body, and then it has to learn how to escape what we call apoptosis, where it has to become immortal. Because typically, if you have a progenitor cell over here, it can divide a certain number of times, and then it's going to burn itself out and die. Cancer cells have learned how to keep dividing without dividing. They become immortal. So initially, when a cancer forms, that's all they know how to do, just divide and survive. They sort of divide and they spread out radially. That's called a melanoma in situ. That's the earliest form of melanoma you can get. Now, if you leave them alone, over time, they're going to keep dividing, and they'll make more mutations, because every time they divide, they copy their DNA. They may make an error here or there. Eventually, they'll make more mutations. But if you think about it, in order for a cancer to learn how to do the bad things we don't want it to do, to metastasize, to go somewhere else, it's got to learn how to do a lot of things. It's got to learn how to basically lose its cell adhesions, stop sticking to other cells. It's got to learn how to break up the extracellular matrix and divide through it. That's the scaffolding that holds your tissue together. It's got to learn how to get through the bottom of the skin, how to get into the bloodstream, travel, avoid the immune system, and grow wherever it lands. So you think about it, it's got to make a lot of mutations before it learns how to do the bad things that it can do. And what we're really trying to do when we get this path report is basically figure out what's the chance that this cancer's learned how to do that thing. So we do this process called staging, which is really just an educated guess on what's the chance this cancer's learned how to do the bad things and has spread somewhere else. And it turns out to us, when we look at these path reports, there's three real factors that help us determine that right away. And that's the Breslov depth, the mitotic index, and the ulceration. And I'll go over those a little bit. The Breslov depth, basically, the pathologist, when he looks at that specimen, he looks at it in cross-section, and he measures how deep that melanoma has grown into your skin from the basal layer of the skin. As you can see on the table on the right, that correlates with how well you're going to do. The deeper it is, and if you think about it, the deeper it is, the more chance it's had to divide and make those mutations, the worse you do. The mitotic index. Basically, a mitosis is medical speak for saying a dividing cell. Basically, the pathologist, when he gets that specimen, puts it under a microscope, and he counts up how many cells he sees dividing. That's what these arrows are pointing to. Those are dividing cells. Those are nuclei actually splitting. These are normal. And when you think about it, the more mitoses you see means the faster the melanoma is dividing, the more aggressive it is. You see very few mitoses. It's more of a slow-growing indolent melanoma. It's usually reported as less than 1 or greater than 1. Ulceration is one of the more aggressive features that we see. So if you think about it, every cancer is basically a ball of cells that's getting bigger and growing as it gets bigger. And as it gets bigger, the picture on the right shows you, it needs to recruit its own blood supply to feed itself. And if it's growing so faster that it can't feed itself, the top part of it sort of starves and dies and ulcerates, and you get sort of an ulcerated lesion like this. Okay? That's a bad thing, as you can imagine, if you have that. And one of the things I do want to comment on Clark level. Clark level was sort of one of the initial ways of characterizing depth. Just like Breslov depth, except for Clark level, what they were looking at wasn't actual distance, but sort of which layer of the skin you sort of invaded into. It turns out Clark level isn't as predictive as Breslov depth when you're looking at it. Breslov depth is a much better predictive. So we don't tend to use Clark level anymore, and it's actually not getting reported on most path reports anymore. The big thing I want to say about it is a lot of people, when they see it, they get confused about it, and they think that Clark level corresponds to stage. And I usually have to sort of reassure them a lot. Clark level 4 does not mean you're stage 4 melanoma. just means you're basically a deeper melanoma. So that's one thing that we verify for people. Once we've looked at this path report and we've done a physical exam, we can sort of characterize people based on stage, and this is sort of the staging system. Stage 0 melanoma is melanoma in situ. That's the earliest one you can get, as long as you can excise that one negative margin, it never comes back. Stage 1 is basically 1 millimeter or less. That's divided between 1A and 1B based on whether or not you have ulceration or a high lymphatic rate. Stage 2 means you're greater than 1 melanoma, but you're not ulcerated. Sorry, stage 2A. Stage 2B means that you're greater than a melanoma, but you're ulcerated. Stage 3 means you have lymph nodes, either detected by a sentinel lymph node or we can clinically detect those on exam. And then stage 4 is obviously you've spread somewhere else outside of the lymph nodes or the primary site. So typically when you come to see someone like Eric or I, we'll do a workup preliminary. The things that we'll do eventually a history and physical examination, dermatologic exam, we'll get a detailed personal and family history, and then we'll pay special attention to the lymph nodes that drain that area and look around the skin and anything else around that area. And in terms of tests we might do additionally, there's several options that a surgeon can do to work up melanomas afterwards, or after you make the diagnosis. Those options include a blood test, LDH. LDH is not actually a tumor marker, like you think of for CEA for colon cancer. And it turns out that the utility of getting a cross-sectional imaging like a PET scan is very low. 0.5 to 4% of patients will show up, if you order a PET scan on them when they show up with stage 1 or stage 2 disease, will have a positive finding on the PET scan. You actually have a higher chance of having a false positive on a PET scan with that stage of melanoma than you do of having something new. Now, as your lesion increases and as it gets worse, if you have stage 2B or stage 3, the chance of having a positive PET scan goes up to 4 to 16%. So if you look at the NCN guidelines right now, they sort of waffle on the imaging. They say for stage 3 cancer, CT or PET scan is not recommended at the discretion of the treating physician. Generally, in Dr. Whitman's and my practice, we tend to order them in patients that have thicker melanomas if they're ulcerated and if they have stage 3 disease. One of the other things to think about if you're a surgeon on this is someone who has had palpable lymph node disease. They may have deeper lymph nodes, so you do have to image the pelvis and make sure you don't have lymph node disease. Now, stage 4, LDH. LDH is basically, it's not a tumor marker like CEA or CA19 or CA125. It's not a protein that's expressed on melanoma. It's basically, it's elevated. If it's elevated, it means that you have a worse prognosis only in stage 4 disease. So it's part of what we order if you have cancer that's spread. Brain imaging, regardless of stage, you only get imaging of the brain and MRI if you're having symptoms. So we don't routinely order a brain MRI unless someone's having neurologic symptoms. So on to the meat of the talk. What do we do once we've done the workup? How do we treat? And like I said, I've divided this up into what you do with the primary lesion and what you do with the lymph nodes. So this is a primary lesion, and by primary lesion I mean the melanoma where it is. Now the thing with melanoma, unlike basal cell or squamous cell cancer, the thing that we worry about with melanoma is where you see it is not necessarily where it all is. There can be little microscopic spread around here, which is basically the melanoma spreading into the little lymphatics around. We want to make sure that we get all of this out. So the treatment is basically to excise it with a negative margin of normal skin around that cancer to make sure that all of this is gone. That involves basically an incision that goes through the fat to the level of the fascia. The fascia is sort of the connective tissue over the muscle with an appropriate margin. Now, the margin is basically the key of what we have to decide. It turns out 50 years ago, or 30 years ago, back in the 80s, the standard of care with melanoma was to excise with a 5-centimeter margin. That's a hole about that big. Almost all of those patients nearly always required a skin graft, and this was based on studies that showed that melanoma liked to spread in the lymphatics in transit. Breslow, his contribution basically showed that prognosis was related to how deep it was, and we started to question whether or not we needed such big margins and how could we get better margins. So we did several RCTs, which are randomized controlled trials, where you pick a margin and you flip a coin, and one patient gets one margin, one patient gets the other margin, and you see which makes a difference. So this is our guidelines right now. And I'll show you where this all came from so you understand it. In situ, melanoma in situ, that gets a margin of 0.5 centimeters. If you're less than a millimeter, you get a margin of 1 centimeter. If you're between 1 and 2 millimeters, you get a margin of 1 to 2 centimeters. If you're greater than 2 millimeters, you get a margin of 2 centimeters. This is where we sort of get a choice because there really isn't good data. And this is where all our data comes from. All our data affects this area. We have no data that shows this is the right answer, and no data that really shows that is the right answer. That's sort of a guess. Some take-home points before we talk about this, what I just said. No trial has demonstrated a difference in survival based on more aggressive margins. What that means is these margins affect whether or not it comes back right where it is, not necessarily whether or not it's spread somewhere else. But we do know that if it comes back after you've excised it, you have a worse chance, you have a worse survival. There's data that supports 1 centimeter margins for less than 1 millimeter and 2 centimeter margins for greater than 2 millimeters. There's no randomized controlled trial that tells us what to do when you're between 1 and 2 millimeters, and nothing really for if you're greater than 4 millimeters. That's sort of based on conjecture. So this is the data, and I'll go through it really quick because I know this will bore a lot of people, but the first trial that was done was basically a multi-country trial done by the World Health Organization. They took patients who had melanomas less than 2 millimeters, and they randomized them between getting a 1 centimeter or a 3 centimeter margin. 600 patients. The endpoint they looked at was basically OS, which is overall survival, whether or not you're alive or dead, and disease-free survival, meaning whether or not you're alive without melanoma. They followed these patients for 10 years, and what they found was basically no difference in survival. Margin doesn't affect survival, and no difference in local recurrence. Local recurrence means comes back right by where you excised it. And basically they showed that there's no difference, although in the 1 centimeter margin group, there were 4 local recurrence. It wasn't statistically significant, but they were all in patients who had greater than 1 millimeter melanomas. So they concluded from that trial 1 centimeter margins are safe, particularly for lesions less than 1 millimeter. And that's basically where we get this recommendation in our guidelines. Intergroup trial was done in the U.S. This was by Charles Balch. He looked at melanomas that were intermediate thickness, 1 to 4 millimeters. Randomized, again, a large amount of people to either a 2 centimeter or a 4 centimeter margin. Followed them for 10 years. No difference in either local recurrence, disease-free survival, or overall survival. But they do note that if you take the larger margin, obviously, a lot more of those patients are going to require a skin graft, 46% versus 11%. And they did. This was the trial that showed us that ulcerated lesions tend to do worse. That's what brought ulceration to sort of put it on our radar. And they showed that local recurrence, if you had a local recurrence, you did worse overall. And so they concluded 2 centimeter margins are safe for intermediate thickness melanomas, 1 to 4 millimeters. That's where we get this recommendation in the graph. Problem is these two trials overlap right here. We don't know what's right here. There was a Swedish trial. They looked at basically 0.8 to 2 millimeter margins, 2 centimeters versus 5 centimeters. Found the exact same thing, no difference in any of our outcomes. So they concluded 2 centimeters are safe for 1 to 2 millimeter melanomas. That's where we get this. French did a similar trial, less than 2 millimeters, randomized to 2 versus 5 centimeter margins. No difference in any of our outcomes. They also looked at this immune modulator drug, isoprinosine, which no one's heard of, because it had no effect on survival. And so again, they fit in right there. The Brits didn't want to be outdone by the French, so they did a trial. Again, they looked at greater than 2 millimeter melanomas. was they randomized them to 1 versus 3 centimeters. They found no difference in local recurrence or regional recurrence. Regional recurrence basically means coming back in the lymph nodes, or survival. When they pooled whether or not you got a local recurrence or a recurrence in your lymph nodes together, so local regional recurrence, they found there was a difference in local regional recurrence with the smaller margin. So they concluded that 1 centimeter margins for melanomas greater than 2 millimeters are associated with a worse local recurrence rate. And so that's why the World Health Organization trial doesn't encompass this. Because based on that trial, it has to be 2 centimeter margins. So like I said, this is where we go. This is left to the choice of the surgeon what you take in terms of either ignite or in between. Most of us will tend to take a 1 centimeter margin if it avoids doing the skin graft. We'll take a 2 centimeter margin if you have more worrisome features, if you're ulcerated or there's a high mitotic. So how does this work? How do we do an excision? So this is what most people will show up with. This is a melanoma that's had a shape biopsy there. We do what's called a wide local excision, so we excise it with a margin. Draw a margin, whatever margin that is based on the melanoma around it, and we excise the skin and the fat below. And then we try to close that in a straight line. Problem is you can't turn a circle into a straight line. If you do that, your skin starts to look bowed and it looks really funny. So you have to make this an ellipse. You have to make it longer than it is wider in order for you to close it in a straight line and it looks smooth. Turns out that that distance, that length, is usually 3 times the width. That's generally what works out well. That's a good rule of thumb. And if you think about it, most shape biopsies usually are about 1 centimeter in diameter. What does that work out to in terms of what's your incision length going to be if you have surgery for a melanoma? This table sort of shows you. You have a melanoma in situ. That's a 0.5 centimeter margin. So your width is going to be 1 centimeter plus 2 times 0.5 centimeters because the margin goes on both sides. 2 centimeters. Your incision length is going to be 6 centimeters. For a thin melanoma, your incision length is going to be 9 centimeters. For a thicker melanoma, when we take a 2 centimeter margin, your incision length is going to be 15 centimeters. For those of you who don't think like doctors in centimeters, in terms of inches, melanoma in situ is going to be about 2.5 inches. That's about the length of your thumb. A thicker melanoma is going to be about 6 inches long. That's going to be the length of the incision. What do we do if it's under an area where there's too much tension to bring the skin together? So you have to take a wider margin and say it's on your shin or your scalp, where you just can't pull the skin together, the tension won't put it together. You have to do you have 2 options. You can either do a skin graft or what's called a rotational flap. Rotational flap means basically you're moving some soft tissue over from an area, and so you can basically borrow tension from an area where there's less tension. This is what a skin graft looks at. This is on the foot. Obviously, you can't close that. So we put a little skin graft under the foot, and that covers that hole. But you can't do graft with fat. So there's always a little bit of a depression there, as you can see like on this one, because we've taken the fat, but we can't put it back there when we do a graft. Rotational flaps are a little bit better than that because you move the fat on the soft tissue. So some of the common rotational flaps will do this as a rhomboid flap. So you excise this lesion here, you draw a rhomboid, not a square, a rhomboid. Go back to high school geometry. A rhomboid basically doesn't have right angles on the edges. And then you draw sort of this mirror of the rhomboid up there. And then if you look at the diagram, basically that allows you to basically take this wing of tissue and move it over. So you're borrowing more tension from here to here, and you end up with this funny looking question mark type scar. It works really well on like the back or the legs. Another one is this VY flap. This is the common one we do. You imagine you've got this circle here, you can't pull this together. So you make this V incision, and then you move this triangle of tissue over to the right here, and you close it so it looks like a Y. So now the tension that was here is now brought over to this smaller area here, where there's less tension. You can even do that on the 2 opposite sides of the lesion, so you can get more length. This is someone who I did that on. This guy's a baker, actually. He's got a melanoma on the foot. Yes, that does happen to people. As you imagine, he's on his feet all day long. So in an area like this, if you were to skin graft right there, he's got no pad on the bottom of the foot. That would be hard for him. So we excised it, and then we brought together 2 VY flaps like that. And then this is him afterwards, and much better version as a result. So that's what we do with the primary lesions. Now we'll talk a little bit about the lymph nodes. So lymph nodes, basically, the body has fluid that sort of leaks into your space in between your cells everywhere in your body. You know, high school biology will tell you arteries take the blood out and take the blood back. Sounds like a perfect system. It's not perfect. We leak fluid everywhere. The body reabsorbs that fluid through little channels called lymphatics. They run everywhere in their body. They tend to congregate at certain draining basins, like under the axilla, the groin, the neck, or the clavicles. And along those ways, there's lymph nodes in those basins. And lymph nodes, basically, they're filters. Okay? They're like an oil filter or a coffee filter. What happens is if you cut yourself and some bacteria or virus gets in the skin, gets in that fluid, it goes up through the lymphatics, it goes into the lymph node, and it sort of percolates here. And that lymph node catches it and shows it to the immune system, and that's how we fight infections. Why every time you get a cold, which is a viral infection in your nose and your upper airway, the lymph nodes in your neck get swollen because they're reacting to that virus. So if you think about it, skin cancers, melanomas, as they first like to spread, as they go through that skin, they get into that fluid, they travel along in that fluid and they get caught in the lymph node and they start to grow there. And we had seen that a lot of melanomas back, a long time ago. People recognize that melanomas like to go to the lymph nodes that drain that limb, and they like to grow there. So surgeons started asking, well, we know that melanomas like to go there. Why don't we just take all the lymph nodes out and see how they do? And so they started doing what was called elective lymph node dissections 20, 30 years ago. And what they found when they did that, people got a lot of lymphedema, just like in breast cancer. But what they found that there wasn't really a difference in survival when they did that in everyone. That's sort of what this slide shows. If you look at these, there were a bunch of trials that we looked at, they showed no difference in survival, as these 2 columns are showing, between those who got elective lymph node dissections and those who didn't. But what they looked at is they looked closely at the data, they noticed that there were some patients, if you broke it down by subgroups, patients who had thicker melanomas or were ulcerated, patients who were found to have micrometastatic disease in their lymph nodes when they were excised. Those patients tended to do better if they had an elective lymph node dissection. So we started to wonder, well, what happens then if we do it only in those patients that the cancer's already spread to? Are they going to do better? And we came up with the idea of the sentinel lymph node biopsy, which was being done in breast cancer, where basically we realized that if you think about it, most places on your skin or most cancers, they're going to be drained by 1 or 2 lymphatics, which are going to go to one lymph node first, and from there they're going to go to the rest of the lymph nodes in that draining basin. That's the sentinel lymph node. Because if there's no cancer in this lymph node, there can't possibly be any cancer in any of these lymph nodes. If there is cancer in this lymph node, we have to worry about these lymph nodes, and then maybe those are the patients that we want to do these lymph node dissections on and take out all of the lymph nodes. So they developed this technology where basically you could inject wherever the tumor is, and you inject them with a protein that's got a little radio tracer on it. And then with the camera you can see this is where they injected, it went through those lymphatics, and it got concentrated in the lymph node there. And that's the sentinel lymph node. And then you can see where that is, and you can take that out. And this is in the operating room. This guy's using a little gamma counter, a little Geiger counter, to basically see where that lymph node is and excise it. So that's what a sentinel lymph node biopsy is. You take it out. So we did a trial, basically. We wanted to figure out, does this make sense in melanoma? And this was the big trial. This was done by John Morton out in California, and he was sort of one of the godfathers of melanoma surgery. And he basically did this trial called MSLT1, Melanoma Sentinel Lymph Node Trial number 1. And he randomized patients to getting a sentinel lymph node or not, or just being observed. They had a positive sentinel lymph node. This is sort of the schema of it. You randomize to either sentinel lymph node or observation. If you have a positive sentinel lymph node, you undergo an immediate lymphadenectomy, removing all those lymph nodes. If you have a negative sentinel lymph node, you just observe. If you end up recurring the lymph nodes, then you get excised. And if you're in the observation group, you're just observed and nothing happens, you just continue to be observed. If you recur in the lymph nodes, then you undergo a delayed completion lymphadenectomy, meaning we didn't do it right away, we did it when you recur. Importantly, this is the true incidence of nodal metastasis. Turns out this is 16%, and this is about 19%, so they're pretty much similar. It means that the sentinel lymph node is highly accurate in how we're diagnosing. This just shows you that the populations between the two groups were pretty similar. And what this trial showed, that is, if you had a sentinel lymph node biopsy, you had a longer or a better 5-year disease-free survival, meaning you were alive without melanoma at 5 years. Doesn't necessarily mean you lived longer, because the melanoma survival was the same. And what that means is that if you recur locally in the lymph nodes, it doesn't necessarily mean that you're not going to recur elsewhere. So if you recur locally, there's a higher chance that you can recur elsewhere as well. So it's a local therapy. It affects what happens here, but not everywhere else. It did show us that sentinel lymph node biopsy is one of the better predictors of how you're going to do in terms of your survival. If you have a negative sentinel lymph node, the chance of you dying from your melanoma in this study was 9.7%. But if you had a positive sentinel lymph node, your chance of dying was 26%. So it's very highly predictive of how you do. And then what it also showed, that this was sort of contested, but it's a subgroup analysis, going back to this thing. So if you think about it, they compared this group here, those patients that had a positive sentinel lymph node and underwent an immediate completion lymphadenectomy, to those that were found later to recur in their lymph nodes and then underwent a completion lymphadenectomy. Asking the question, do you do better if we detect it early and remove it, rather than do you do better if we, or do you do the same if we detect it later and remove it? And they found that those patients, the group 1 patients, that we detected it earlier on and removed it, they had a better survival. So they do better if we remove the lymph nodes early. We'll just skip over this. Questions most people want to know is, who do we need to do a sentinel lymph node biopsy on? Typically, we want to do it on people that have a higher chance of having a sentinel lymph node. We don't want to do it on everyone, because a lot of people won't have a chance of having a positive sentinel lymph node. So it turns out, a quick rule of thumb, your risk of having a positive sentinel lymph node is about 10 times the depth of your Breslow depth in millimeters. So if you have a Breslow depth of 0.75 millimeters, your chance of having a positive sentinel lymph node is 7.5%. Typically in our practice, we do sentinel lymph node biopsies for melanomas greater than 0.75 millimeters. We rarely do them for melanomas less than 0.75 millimeters, unless they have some features, and Dr. Whitman actually wrote a paper on that. Number one, if the positive transection margin is positive, meaning when they did that shape biopsy, the melanoma went right to the bottom of the biopsy, there's a chance that it could be deeper than you think it is based on that pathology report, or if they have a higher mitotic rate. We tend to do more sentinel lymph node biopsies in those patients, because they have a higher chance of having a positive sentinel. Question everyone always asks on their first visit is, what happens then if the sentinel lymph node biopsy is positive? What do we do? 2 discussions we always have. One is whether or not to remove the rest of the lymph nodes, a completion lymph node dissection, and the other is whether or not to give them adjuvant therapy. There's 2 things that are approved in the adjuvant setting, meaning you removed all the disease, you want to make sure it doesn't come back. One is Yervoy, the other is interferon. I'm not going to touch on that part because I know Dr. Whitman is going to talk about that. But the first part, completion lymph node dissection, what does that mean? So that means removing all of the lymph nodes now in that draining basin where it leads. And what that means on the armpit, that's an axillary dissection. You remove all the lymph nodes basically below the axillary vein, outside the chest, in between the lentissimus, this whole triangle of lymph node patterns here. In the groin, that means removing the lymph nodes that are all below the inguinal ligament between this muscle here, the adductor, and this muscle here, the sartorius, removing this triangle of lymphatic tissue. What are the advantages and disadvantages of that? So the disadvantages of doing a completion lymph node dissection, number one, is more surgery. No one likes surgery. It means we have to make the incision that we did for the sentinel lymph node biopsy a little bit bigger. Because when we remove all this stuff, there's an empty space created. The body doesn't like to have an empty space, so it fills it with fluid. We have to put a drain in to suck that fluid out until that space collapses. That drain's usually in for a week or 2 weeks afterwards. The big disadvantage that a lot of people are worried about is lymphedema. Lymphedema basically means that if all that fluid coming up your leg or up your arm used to go through those lymph nodes, we've removed that passage. So we basically blocked 287, and now there's a big traffic jam behind it, so you can get swelling behind it. The body finds other ways for that fluid to drain, little detours, but sometimes it's not enough and you get swelling. The rate of lymphedema after a lymph node dissection is about 15%. Most of that is minimal, just a little bit of swelling, but some of it can be severe where you get a lot of swelling. In terms of the advantages, number one, we get better staging. We can get a better prognosis, better idea of the prognosis based on the number of lymph nodes that are positive, and we'll get better prognosis. Number two is improved local control. And this is important. We don't want patients to come back like this, where they come back with a big mass under the armpit because there was microscopic disease and it grew. And number three is better survival. Like I said, there was this subgroup analysis on MSLT1 that suggests that if you remove the microscopic disease that may be there, you may have better survival in the long run. We don't know that for sure because this trial really wasn't designed to show that. This is sort of an ad hoc analysis of the trial. We're currently doing that trial to figure that out. There's a trial called MSLT2, which began accruing in 2004. Its goal was to accrue 4,200 patients, and it's already met its accrual. Unfortunately, we won't have the results of that trial until 2022 because it takes a long time to follow these patients. But basically, their trial was basically, they looked at intermediate thickness melanoma. If you had a positive sentinel node, you were randomized to either having a completion lymph node dissection or being followed closely with ultrasound surveillance. Excuse me. If you didn't have a positive sentinel lymph node, one of the other analysis they were doing was looking at PCR to see if they could detect DNA from melanoma in the lymph node and then randomizing them based on whether or not that was positive to completion lymph node dissection or not. We don't have that results, but we will have that in about 6 years. So, take-home points. Treatment of the primary site of melanoma requires a wide local excision to remove any residual disease. Margin depends on the depth of the primary melanoma. Margin size impacts local recurrence, but has no impact on your overall survival. Sentinel lymph node biopsy is the most important predictor of prognosis, and completion lymph node dissection improves local recurrence. It's unclear if it affects overall survival yet, but we will know that results in 6 years. Any questions?